Let's now chat to Professor Salim Abdool Karim. He's the Chairperson of the Ministerial Advisory Committee on COVID-19. Good evening, Prof. Always lovely to chat to you. Let's start in the Eastern Cape. Its infections are fairly neck and neck, just a little behind us here in Gauteng. But of course, Gauteng has much more hospitals, many more resources. How concerned are you about the Eastern Cape at the moment?
Yes, good evening, Sally, and good evening to the viewers. When we look at the deaths that are occurring in both the Western Cape and the Eastern Cape, we get some idea of how they are tracking with each other. And essentially, the Eastern Cape is running at around just a little bit over 2 weeks behind where the Western Cape is. But otherwise, if you go back 2.5 weeks ago, that's exactly where the Eastern Cape is right now. So we expect that the number of cases will grow. I don't think we're going to see as explosive a spread as we saw in the Western Cape because density is less of an issue. But the big concern is that the number of beds and the number of ICU beds is much lower in the Eastern Cape. And so quality of care is going to be important, and the availability of field hospitals will be particularly important.
It was quite interesting that you talk about bed availability in the Eastern Cape. Earlier this week, the Premier, Oscar Mabuyane, was saying he would like to see that alcohol ban be reinstated because of exactly those concerns. And earlier, Keith Klutter, head of health, was saying that in the Western Cape, their 5 major hospitals have experienced a 60% surge in trauma cases since the lifting of that ban on alcohol. I'm wondering what your view is. Banning doesn't really work long term, but certainly is it something that you would recommend? Would you like to see perhaps in areas that are under severe pressure with hospitals really battling for beds? Would you say that putting that ban in place again, the alcohol sales ban, might be something to consider?
Yeah, the problem with alcohol is that you begin to utilize key services that are actually required by COVID patients. And those services are the emergency room, where you've got patients coming in with alcohol-related violence, alcohol-related motor vehicle accidents, and then direct alcohol-related medical problems like pancreatitis. And they often need medical care, which is admissions to key beds that we need, including ICU and surgical time. So all in all, it really poses a problem. But I think for me, the big issue is that as soon as you start getting large numbers of COVID patients coming into the emergency room, every patient coming in for a non-COVID condition, such as a motor vehicle accident that's alcohol-related, that person is now at risk of acquiring COVID because they're in the emergency room at the same time. So there are many issues that are impacted by the availability of alcohol and the way in which alcohol leads to the use of healthcare services.
So do you want the ban back?
I think it needs to be used judiciously. I'm not in favor one way or the other, but I think if we are going to get to a situation where our hospitals are under pressure, we will need to look at instituting some kind of restrictions on alcohol use.
Let's talk about the testing backlog. I understand that some progress has been made in clearing that. Just tell us where it's getting cleared and where your areas of concern are still.
The backlog in testing really grew from around the middle of May, and over the last 4 weeks has increased quite substantially. Over this last few days, there's been some clawback, and I gather that we are in the region of around 60,000 plus minus in terms of the backlog. I think what's going to be particularly important is that we prioritize the existing specimens coming into the laboratories. And that means that hospitalized patients, healthcare workers, outbreak investigations, they get priority, as opposed to workplace screening and asymptomatic screening, which really is not a high priority for us at this stage. So if we can prioritize, we can avert the immediate crisis. But the long-term solution really revolves around us being able to secure more tests. And that's really a problem because the whole world is trying to buy exactly the same tests we are trying to buy. And so we have to join the queue, and we can only secure a limited supply. And so we have to look at alternatives. And so I'm very pleased that I was talking during the weekend with my colleagues at the Africa CDC in Ethiopia, and they were talking about their negotiations to try and secure 15 million tests for Africa. And so I hope that that's going to be successful, and if it is, then we would address some of our shortfall as well.
How close are we to getting antibody tests here in South Africa, which will obviously give an indication how many people might have immunity in the country?
Yeah, I think antibody tests are going to be important in terms of understanding where we are in the epidemic. Unfortunately, antibody tests are of no value in diagnosing a patient with acute disease because the antibodies only become positive roughly about 2 to 3 weeks after the symptoms onset. So for the first 2 weeks or so, 10 to 14 days, an antibody test is not helpful. But after that, and particularly when we're investigating outbreaks and we want to know who has been exposed, who has been exposed without symptoms, in which case, a PCR swab is not helpful. So that's where it's particularly helpful. We understand that there have been over 100 of these tests that have been submitted to our regulatory authority, and we are waiting to hear from our regulators as to when and which of the tests will be approved. And I anticipate that that should be in the near future because all of us are waiting for such an antibody test to use in this very judicious way.
Yes, it certainly will be very useful. I have to ask you for an update on an issue that we've spoken about extensively, and that is the way COVID-19 deaths are recorded. Now, there has been an acknowledgement that some of the deaths listed as COVID deaths were not really correctly listed as such. For example, the teen who died of their injuries in a car accident but was tested for COVID and yet made the list as a COVID death. So I have to ask you, how soon are those errors going to be corrected in the list of, over 1,200 deaths? And should we expect to see a change in the number of people listed as COVID deaths?
Yes, as we in South Africa have adopted the WHO approach to categorizing deaths from COVID. And essentially it's looking at every patient in relation to 3 criteria. The first is, if we know definitively that the patient has died of COVID-19, then that should be recorded as the primary cause. If it's a probable death, in other words, there may be other intervening factors, then we still record it as a COVID death because it's the probable cause of death. But in the instance where a patient might have died of some other condition, but COVID may have contributed, and we cannot rule that out, then we call that a contributory cause, and in which case it needs to be recorded as a contributory cause. And right now we are simply just talking about COVID deaths. We're not distinguishing between the different categories, and I think that that's the issue you're relating to, which is, can we make those distinctions? And in instances where there are where even the presence of COVID-19 may have been just coincidental and not a contributory cause, then that needs to be corrected. And so a process is underway which is involving the Medical Research Council to actually look at this issue and set in place the processes to quality assure the recording of deaths.
And how soon do you think we will see that new list?
Deaths is it takes a long time because of the process that it has to follow. So I can't give you a date. I can tell you that it's already being addressed, but I can't tell you when you will see a revised list. That's beyond my ability to give you a definitive date.
Well, thank you very much for your time this evening. Always wonderful to talk to you. Professor Salim Abdool Karim, the Chairperson of the Ministerial Advisory Committee on COVID-19.